Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. In this group of the lectures, I'm going to go to step by step for right ventricular evaluation, including dimensions and systolic function and everything. In this group, we will have talk about RV dimensions or base, mid, length, and RVOT, all those three RVOT measurement, fractional area change, myocardial performance index for right ventricle, TAPC and TAPSV, right atrial pressure, how we measure it, systolic pulmonary artery pressure, and diastolic pulmonary artery pressure, how in echo we measure it, and finally, right ventricular walls and perfusion coronary artery. For those reviewing this lecture, right ventricular focus view, go to this one. For getting view, IVC view in the classic and non-classic, this lecture. For IVC and middle hepatic vein, Doppler and all those other are finding in normal and abnormal situation in this clip, and finally right ventricle free wall strain in this lecture. In this one, I'm going to talk about right ventricular dimension, how we measure it, how we get images and measure, and fractional area change. Let's do it. Right ventricle has a uniform and unique shape, opposite of the left ventricle that we have cone shape, almost or bullet shape. Right ventricle has a triangle shape, especially at the base of the RV. You can see up to the mid. We can appreciate two region or area here. This region that go connected to the pulmonary RVOT or anterior part, as you can see here. This is a different MRI of the heart, short axis, PZAX on the MRI at the level of mitral valve at tip of the papillary muscle. We can appreciate those two regions, RVOT region, anterior, and inlet region of the right ventricle that almost is rectangle, and these two different level, especially close to the base at this level and here. So for right ventricular, we have to, when we are going to talk about dimensions of the right ventricle, we have to know which region we are talking. So we have two regions as RVOT and inlet or main part of the right ventricle or inlet of the right ventricle. On the plaques and apical tree, our sector plane pass through this line. As you can see, imagine here, or on this one in this way. And on the apical 4, our sector passed through this line that passed through the basal or posterior part, and here you can see this is our sector. On the PZAX or parasternal short axis view here, as you can see, our sector passed through this region that is like this way, but you don't see it on this from the top cutting. Here we cut this way, and so we have three different dimensions on the basal level or inferior level and anterior level. Now let's go see how we measure, how we get those images and how we measure those dimensions. Measuring apical window. We have two windows for the two views for the measurement of right ventricle. Apical for classic and right ventricular focused view. As I mentioned in another clips, specific allocate for this view, just the, as I mentioned, just the only difference is that insonation to the right ventricle free is less parallel, so we have more clear on the free wall, so we can determine the border of the endocardium of right ventricle. Otherwise, there is not any, shouldn't be any differences between apical fourth chamber and right ventricle focus view. Just go check that clip I mentioned at the beginning of the lecture. So whichever that give you clear right ventricle border, take that one, and we go at the end to measure three parameters. Those three parameters are basal, mid, and lens. Let's go before that. I want to give you a tip. The correct four-chamber view, RV focus or classic four-chamber, is the view that all those chambers, mean both atria and both ventricles, are in the largest their size at the same view. That is the general rules. For that matter, just sweep the twist a little counterclockwise, clockwise, make it those four chambers, as you can twist it, you can see all four chambers are in the largest size at the same time. Usually at that moment your marker will be between something between 2 and 3 o'clock, and your sector pass through this line. As you can see, those landmark that beside of the chamber size can help you are in the correct view is cross of the heart here. It shouldn't be open LVOT, as if is LVOT open mean you are angling fine, up. If you are angling down, it become close to the basal view or coronary sinus view, and both atria start become smaller. As you can see here, when you get basal view, it is suddenly left right atrium here especially decreased, and here cross it go apical between 4 and 5. That even though this patient has AVR, aortic valve replacement, is thickening that area because of that. But just keep up those tips for this is your image or not. And before you go measure, look back and forth and make determine where is the tip of the right ventricle. Usually, tip of the right ventricle maximum is 1 centimeter lower than apex of the right ventricle. So if here, as you can see, apex of the right ventricle is here, left ventricle is here, right ventricle should be here. So back and forth, make sure determine chorda tendini, where is your chorda tendini, papillary muscle, and free valve before you go for measurement. When you determine your border, then freeze it, cine loop, go to at the end of the diastole that usually correspond with the Q or R, and all valve closed, all four chambers are at the largest diameter. Then you have to measure basal diameter, that is largest diameter at close to the tricuspid annulus, sometimes at next to the annulus, sometimes a little beyond, above that one, doesn't matter. Go largest area that you can see close to the tricuspid annulus. As you can see here, tricuspid annulus, hinge, this is your this line will be your tricuspid annulus, and make it this one inner to inner without including trabeculation and any other structure, just compact myocardium. Make it this measurement line parallel to the tricuspid annulus. As you can see here, this is your tricuspid annulus, and this measurement is parallel. The second one is mid. You go halfway between the tip of the right ventricle and annulus here, so almost is here, from here to here and here to the apex is almost halfway, usually below insertion of the lateral papillary muscle at this level, and make it without including papillary muscle. Go endocardium to the endocardium without including trabeculation. Then last dimension, you measure length of right ventricle. For that matter, You go put it the tip of the right ventricle, apex, and then make it and connect it and go all the way to the mid of the tricuspid annulus, not the first basal, no, that the annulus line here. As you can see, it came up to the here. That is your correct way measurement for right ventricle dimensions in four chamber. Some cases those dimension doesn't look enlargement, as you know the size of the abnormal is for the base if it's over 42, for mid over 35, and for length over 85 millimeter. That's each of them indicate right ventricular enlargement. But sometimes even this dimension you measure is not enlargement because we don't include body mass index. As a general rules, right ventricle dimension, especially at the base, should be less than 2/3 of the left ventricle at the same level. So with eyeball, if you can see or measure this one and base of the left ventricle, if they are very close or equal, you can say very easy right ventricular at least moderate enlargement. If right ventricle by eyeball guessing or the dimension of the base and here left ventricle base for right ventricle is bigger than left ventricle, we have severe right ventricular enlargement. Just making sure that you are not off axis, even following those rules that I mentioned. You have to, this measurement correspond with the other view, especially subcostal four chamber view, and other area for the plaques as RVOT. When we have basal, this part or posterior of the RV is dilated, and we measure on this view four chamber, is almost always this superior part or anterior part that belong to the RVOT should be enlargement. So if your measurement here doesn't match up with measurement RVOT, there is not correct view and error in the view and measurement. Just match up your finding with other view too. The right ventricle is RVOT, that is the outflow tract of the area of the right ventricle. Whenever on the plaques we see RVOT dilated and we are not low axis plaques view, because if we move it low, it looks like bigger. So if we see on the eyeball guessing is dilated, or on the P-ax you can see dilated, we have to measure. Beside of those situations, whenever we have right ventricle diameter in apical 4 looks dilated, 100% we have to come measure this 3 RVOT diameter. First, we go for the RVOT on the plaques. When we have a good plaques that doesn't show up tricuspid here, left atrium is correct, coaptation at the center, then we go measure at the end diastolic, almost the largest spot perpendicular to the free wall of right ventricle and connection to aortoventricular junction, the septum to the aorta, that this level. This will be RVOT, and in normal people should be equal less than 3.3 centimeter. After that, we go on the P-ax, we measure two RVOT. One of them is proximal, as you can see here on short axis at the level of the aorta. Then we go measure again at the end of the diastole. We measure perpendicular to the free wall of the RVOT here at 12 o'clock and inner of the aortic ring, as you can see here. Normal in the RVOT proximal in male should be less equal or less than 40 millimeter, and female less equal or less than 42 millimeter. After that, we go for the Rvot distal, that is close to the ring of the pulmonary valve. For that view, we have to go from the P-ax at the aortic level, fan to the left of the patient and twist a little more clockwise until you can see aortic ring wall, aorta, pulmonary artery the same. You can see pulmonary artery and completely pulmonary valve. In that situation, we go at the end diastole and we measure right just before the pulmonary ring, inner to inner, at the end of the diastole. The normal size for the Rvot distal in male is equal or less than 20 millimeter, and in female equal or less than 28 millimeter. When we have this view and you see here is dilated, right away we have to measure pulmonary artery 2. For that measurement, we go for the largest diameter when we have clear border, largest diameter pulmonary artery, or just up to 1 centimeter below the pulmonary valve ring. At this level, inner to inner, at the end, the same time, end diastolic, it should be in both gender equal or less than 25 millimeter. If pulmonary artery enlarged more than this, you have to open the right pulmonary artery and left pulmonary artery with just twisting a little more, slide down, angle up. You can see both of those right and left pulmonary artery, and then measure those two. Fraction area change is another parameter, good parameter for evaluation of the right ventricular systolic function if it performed correctly. For that purpose, we have to get right ventricular focused view or apical four chamber, as long as we can see the border of the free wall of right ventricle and apex of the right ventricle. So for example, on this case, we have to move our probe a little medial of the patient, and you can see apex of the right ventricle and free wall much better. Or we go right ventricle focused view and get our view, and then we go for the measurement of the area of the right ventricle at two times. One of them is end diastole and another is at the end of the systole. For that purpose, we go end diastolic when the largest diameter, and we can see clear free wall at the almost correspond with the Q or R, wherever or whichever is clear and largest. Then we trace from the tricuspid annulus and cutting trabeculation. We don't include trabeculation papillary muscle. We go close and at the apex of the right ventricle, then trace the compact septum and then end it to the tricuspid annulus. Double click machine. If you use cal on the bottom cal in the machine automatically calculate for us area of the right ventricle at diastole. Then we go at the end of the systole, that is correspond almost with the end of the T wave in the EKG. Then we go the same way, trace it, and finally we can calculate fraction area changes percentage with this formula. Fraction area change at the diastole minus fraction area at the systole divided to the diastole and multiple 100. Normal fraction area changing of right ventricle in male is equal or more than 30%, and in female is equal or more than 35%. Right atrium measurement should be done in all cases, but this is very important when we have right ventricular enlargement or pulmonary hypertension or any shunt intraatrial septum or interventricular septum. We have to measure right atrium. For right atrial measurement, we have three techniques. Disc technique for volume that we use for the left atrium, as the if you remember from the Simpson technique, this technique. And the other two technique is diameters, minor and major, and sorry, or right atrial area. For those measurement, first we get it like the classic four chamber, that all four chambers are at their largest size, then freeze it, and we go at the end of the systole that correspond with the almost end of the T wave on EKG. Then we go with using cal bottom and right atrial area. Then we trace started from the annulus of the tricuspid valve. Doesn't matter, start from the medial or lateral, is better from lateral. Start there, endocardium. Don't go into the IVC. You sometimes you can see here. Just make it unique and correct and clean curve without any zigzag and going in and out. Just trace endocardium of the right atrium and finish at the annulus. Double click, machine give you area. The normal right atrium area in adult should be equal or less than 20 centimeter cubic, and in female equal or less than 19 centimeter cubic. For the diameter, we have two diameter as the right left atrium. Here on the four chamber, we have two diameter or dimension as in for the right atrium. First, we go again the same time at the end systolic. We find the largest spot on the transverse. Then we go measure inner to inner at that spot parallel to the tricuspid annulus. So your line of measurement should be almost parallel to the tricuspid annulus line. Then that will be your minor dimension. The normal should be equal or less than 4.4 centimeter. For the major or major dimension or diameter, we go put start at the middle of the tricuspid annulus, almost here, and make it a perpendicular to the minor dimension. Here, as you can see, don't make it go largest. Go from the middle and perpendicular to the minor. This will be your major diameter of the right atrium. Normal should be equal or less than 5.3 centimeter. To the right ventricular hypertrophy, for example, pulmonary hypertension or any cardiomyopathy that we see looks like right ventricular hypertrophy, we have to measure free wall of the right ventricular thickness. For that purpose, we go subcostal. Subcostal four chamber view is the best view. After getting good subcostal four chamber, that try with heel toe and maneuver, make it the free wall almost perpendicular to the sound beam like this. Almost free wall is horizontal on monitor, so it's perpendicular. Then zoom on that area and find the epicardium and endocardium. Here you have to be aware, most of the patient they have pericardial fat pad. How you can differentiate it? Pericardial fat pad, pericardial fat pad, and epicardium. Just cine a loop and see those two layers, epicardium and parietal pericardium. They slide over each other, as you can see here. These two, this hyperico and this one, these two sliding over each other. You know, okay, that is the border of the epicardium. On this case, you can see trace pericardial effusion, and it tell you that this is exactly right before this fluid on echo is your epicardium. Follow that line and that will be your epicardium. One spot for measurement, you put one cursor and freeze it, and at the end of the diastole, close to the papillary muscle, before papillary muscle, any spot that give you clear thickness and border, but not to the annulus, a little above the annulus, because here, as you can see, usually is thinner. So some spot before papillary muscle is the best at this level. Then you put it cursor one marker over the endocardium, epicardium, and another over or on the endocardium without including papillary muscle or chordotendini. That will be our measurement for the free wall thickness of the right ventricle. The normal size should be equal or less than 5 millimeter. So this lecture is free too for public, so please share it. Up to the next time, have a wonderful time.